So here we are going to start with the general approach on the Simman stations. The general approach is we have given loads of detail on the general approach. If you want to see on your notes, I don't know if you had accessed or not. Okay. So at the moment we will be talking about general approach. You all should use a mobile application introduced by the Resuscitation Council that is called iResus. If you want to use, you can. That's very good application where you can get all the updates in the guidelines. Okay, so these are the general principle where you want to over the Resuscitation Council suggests you that ensure your safety and the safety of the patient and follow ABCDE, identify any life-threatening conditions early before moving forward. So that's very important. Introduce yourself politely, sympathy, empathy, all those things should be introduced, and then you carry on. Do not delay to shout for help if you think that you may need. Okay, so these are the general principles, and the resuscitation guide council suggests to obtain the IV line as soon as possible before the patient collapses, because it can become very difficult for you to obtain IV line if the patient collapses. Okay, and also you may need to introduce or inject some medications, so that's very important that you obtain the IV lines as soon as possible. So it does not have to be in the circulatory part or C part. Okay, so I've seen many candidates, they're struggling with the when we can give them the IV line. So if you have enough people around, you can always, while you are still assessing the breathing, you can always ask your colleague, can you please put IV line? That's a general principle. However, talking now, coming to your OSCE exam, you will be alone in most of the situation. In few situations, you may have a nurse available. So you can go through all those things. GCS, it is very important, but you do not need to worry about this until you reach D. Okay. However, if the patient is unconscious in the beginning and you see that the patient is not talking to you, the next thing that you want to do is no need to worry about doing the full GCS, but look, listen, and feel. Okay, if the patient is breathing, then you follow your ABCDE. Okay, so that is the first thing that you want to find out if the patient is unconscious. Okay, uh, before you go to jump to Glasgow Coma scale or AVPU scale, you need to make sure that the patient is breathing and he has a pulse as well. Okay, that's important. These are just a few things that are going to be helpful when you perform, when you go in your exam. Okay, so just go through them. You don't need to memorize everything. This is a sepsis 6 that you can go through. 3 ins and 3 outs. What are the ins and outs? Then important life-threatening conditions and their management. That's very important. Where you can be penalized in your exam, what the expectations are in your exam. It is very important that you know the right dose of the medication and right route of the medication. Do not delay. That is the first thing that you need to do when you identify any problem. Okay, as soon as you identify, treat it before you move forward. Okay, uh, so now talking about those problems, the common medications that you may need to remember for the sake of your Simman examinations, Simman stations. There are not many, there are only few, they can be counted on the fingertips, and their routes, their dose, and their exact indication should be in your mind. Okay, they should be on your fingertip. If you have any help in your OSCE, like sometimes you may have a nurse in there, you will have to give them a clear instruction. Okay, it cannot be that I want to give my patient normal saline and it will not be considered done. So you need to make it clear that I want the patient to have 500 mils of normal saline over 20 minutes. Okay, then only they will consider that you have done. Okay, otherwise do not be surprised if you see the bad result after giving simply normal saline, because normal saline for them does not carry any meaning until you give them the clear instruction. Okay, similarly, do not assume that whatever you say will be done. So you need to show that by acting with the patient, with the Simman. Okay, uh, the other medications that you may need to use in your different stations are glucagon, adrenaline, then dextrose, chlorpheniramine, heparin infusion, naloxone, salbutamol. Okay, so these are very important medications that you may need to use. Okay, their doses and their clear indications should be on your fingertips. Okay, now moving to the airway assessment. Moving into the airway assessment, how we assess the airway, it is quite important that you go and talk to the patient. Okay, if the patient is talking to you, then it means clearly the patient's airway is patent. Otherwise, look for any. There are many other signs and symptoms that you may see on the patient's face, like the audible signs and visible signs. On the visible signs, you can look for if there's any nasal flaring, if there's any pursing of lips, if the patient is struggling. Okay, so all those, if the patient is distressed. Okay, all those things are quite uh, important to look for. Okay, so the patient may have stridor, and patient may have gargling sounds. Okay, if you see any trauma of the face, then the patient's airway is at risk. Okay, now going to the background history, if the patient's history is suggestive of anaphylaxis, it means the patient's airway is patent. So all those things and any other signs of risk of the airway compromise should prompt you to the next section, which is giving adrenaline. You should not delay if the patient is at risk of airway obstruction, or you think that the patient might have had allergic reaction. Without any delay, give adrenaline. That is the first thing. Okay, so then you carry over your assessment, that's no problem. Okay, however, if you do not act now and you want to carry on your A to E examination, then give adrenaline, you will be penalized. Okay, that will be considered delayed response to the problem. Okay, and you will not pass that exam, that station. What are the possible interventions? Target oxygen saturation. This is what we want to do. We want to just go through the guidelines, and based on the patient's COPD status and their uh, any other problem. So we target the oxygen saturation 94 to 98 for the normal person who does not have any history of airway COPD. But those who have a history of COPD, we should keep the target between 88 to 92. Now this is very important for us to understand, and you guys to keep in your mind that we always, most of the students, they always start considering that the patient has is hypoxic. So hypoxic, by definition, there are two different definitions for the COPD and non-COPD. For the COPD patient, 92 is not hypoxia, whereas for the non-COPD patients, it is a hypoxia. Does it make sense? Okay, because if the patient is a COPD, then 92 is normal for them. Does it make sense? In the beginning, it is important that you can start the patient on high flow oxygen. The most important thing that you want to verbalize and you want to mention that I will do ABG of my patient, arterial blood gas, because in many of the situation, the oxygen saturation may be wrong. Whatever you see on the monitor with your eyes may be wrong. Okay, if the patient is severely anemic, if the patient has some other problems like maybe cardiac problems, okay, or Raynaud phenomena, Raynaud disease, all those things can cause erroneous SpO2, can give you the wrong readings. So better you always mention that I will do the arterial blood gas, I will confirm the status of the patient. Okay, so what are the possible other problems? If you see any visible foreign body in the patient, try to always dig it out under the direct vision. Try to use the instruments if you have available. Okay, do not just scoop it out with the little finger, with the big finger. So those are wrong approaches. So if you find any foreign body in the patient's mouth, okay, in their throat, remove it under the direct vision. What are the diagnostic workup? We have already mentioned about the ABG, and depending upon your assessment, you intervene, then you move forward. So the next thing that we want to do is a B. There are parameters from A to E. In A, the main parameter is the patient talking to you? Does the patient look settled, or does he appear to be distressed? Okay, that's the main parameter. For the breathing and respiratory rate and oxygen saturation, these are the two main parameters, okay, that will tell us what is happening with the patient, okay, in addition to performing the full clinical examination. So you need to examine the patient by exposing. However, for the sake of your examination, in OSCE they normally suggest do not expose a patient, assume exposed. Okay, doctor, is a doctor, sorry, I forgot your name. Mahbuba. Okay, you need a cup of coffee.
Yes.
Okay. Yeah. So in B, we inspect the patient, assume that the patient, usually they say assume, okay. In a few situations where they want to give you the findings, like they can give you the rashes by putting a piece of paper, or by doing some by using some additional makeup on the chest. They may put a few dots, okay, that means the patient has some problem. Normally they suggest you, okay, assume it is the patient is exposed. Then you move forward to B. In B, the main parameters are respiratory rate and SpO2. Then perform the clinical examination by inspection, palpation, percussion, auscultation. Okay. Ideally, we should do all those parts of the assessment on the front as well as behind the patient. However, for the sake of this examination, you may not be able to do it. Okay, the way they can simulate the things are in terms of simulation. You may see blue light in the mouth. That means a cyanosis. Okay, sometimes they put blue light just behind the teeth. It means a central cyanosis. Okay, so be careful whenever you go and see any patient and the patient is unwell. Always try to look into the mouth. Okay, there may be loose denture as well. Okay, if the patient's denture is loose, then mention about that. uh, in the assessment, quick assessment of the respiratory system, including looking for the tracheal deviation, that's also very important. Okay, uh, then what are the intervention? It depends on your interventions, depend on what you find the problem is. Okay, if the patient has a pneumothorax, then the most important thing for you to do is,
Inserting.
yeah, that's for the tension pneumothorax. Okay, we denote for the pneumothorax, we can get the ABG. That's the most important thing. Then get the X-rays as well. So where you are suspecting, depending upon the size. Okay, how distressed a patient is a patient, does a patient seem to be compromised or not? Okay, in the tension pneumothorax, we get the tracheal deviation, we get hyperresonance. So in that case, that's the emergency. Okay, we do the needle thoracosynthesis, then send the patient for the X-rays. Okay, do not wait for the X-rays in that situation, and do not wait for the ABG. If you feel, especially if the patient is distressed, you feel that the trachea is deviated and there is a hyper resonance on one side, you do the first thing that you should do is doing the needle thoracosynthesis. Okay, depending upon other findings, hemopneumothorax, cardiac tamponade. For the cardiac tamponade, the pericardiocentesis, hemopneumothorax, chest drain, all those things. Okay, what are the diagnostic workup? Depending upon, again, what you find in your assessment, uh, you may do the chest X-ray, ABG, CTPA if you are suspecting pulmonary embolism, CT aortogram if you are suspecting dissection, and similarly any sputum and culture if there are crackles, and or anything like you're suspecting severe pneumonia and stuff like that. Okay, now before you move to C, the rule is you go back to A and B. Okay, that is the rule. A, B, C, D, E. That's the protocol for us to move forward. However, after every intervention, you need to go back to A before you move to the next step. That is a rule. Okay, after you've intervened, say for example, you found that the patient had some maybe pulmonary embolism. You mentioned about doing ABG, ECG, echo, or whatever, the D dimer. You mentioned about doing this chest X-rays as well as a CTPA. Before you move to C, the rule is you come back to A again. Make sure that the patient's airway is not compromised. The quickest way for you to do that is looking on the monitor. At this point, you should mention that if the patient is not already attached to the monitor, you should mention that I want the patient attached to the monitor. Okay, before you go to C, you need to have the patient on the monitor. You need to you must have mentioned about doing the ABG, chest X-rays, okay, and always start the patient on oxygen. Depending upon their COPD status, you can start either high flow oxygen, that's a 15 liter, or you can go with the lower one starting with the 4 or 5. However, it again depends how hypoxic the patient is. If the COPD patient is badly hypoxic, say for example 82, 83 oxygen saturation, you can start them on high flow oxygen. Okay, the major risk that we are worried about this patient who have the COPD and are on oxygen is a carbon dioxide retention. Okay, that does not happen just immediately, it does not happen straight away. You can start the patient, treat the initial hypoxia with the high flow oxygen, okay, get the ABG and titrate it accordingly. Okay, so for the to treat the initial hypoxia, you may need to give the patient high flow oxygen even if the patient is COPD. Okay, so the good thing to avoid any penalty is that you mention I understand or I know my patient is COPD, however he is very hypoxic. I will monitor him further for the oxygen by doing the ABG. Okay, now we have done airway, we have done breathing. The next thing is circulation, and at this point so far we have attached the patient to the monitor, we have attached the patient to the oxygen, we have requested the ABG, we have requested chest X-rays, as well as we have mentioned about doing any other sophisticated investigations including CTPA, including ECG if we think that there may be the PE. Okay, so all your suspicions and your assessment should guide you what sort of investigation you need, what sort of interventions you need. Okay, and what are the other specialties that could be helpful for this patient. Okay, so talking about the airway, the main specialty that can be helpful for you is ITU or the anesthetist. Okay, if you think the patient's airway is at risk, then you always mention that I understand or I feel my patient's airway is at risk. I will call the ITU team or I will call anesthetist. Okay, that's very important. So now moving forward from A to E, the next step is C. In C, what we do is, what are the parameters of circulation? What are the parameters of assessment of circulation? Is capillary refill time, okay, pulse rate, and blood pressure. Okay, these are the main parameters that you are all aware. Okay, but the fourth parameter that I want you to add with this is temperature. Okay, although according to the guidelines, if we read the notes and stuff, okay, temperature, checking temperature is mentioned in E, but I always suggest you guys to keep it in C, because this is C is the main system that will be compromised if there is any change in the temperature. Okay, so that is the main reason. If the patient is hyperthermic or hypothermic, you see the changes in their blood pressure and the pulse. Okay, so and based on your findings, your investigations will be listed and you will follow that plan. Okay, so you will be able to chart your plan. Say for example, if the patient has a 39 temperature, you will start thinking about giving the IV fluids, giving IV antibiotics, and giving paracetamol. Okay, and doing the cultures, doing the ABG, all those things. So there is a long list of investigations and the intervention that you can do if you are aware of the temperature. Okay, so do not delay. Keep this parameter in C so that you avoid any major mishaps in your exam.
should we verbalize right away after examination if we needed these investigations?
Yes, yes, yes,
Or
yes.
just wait until he done?
No, do not wait. Otherwise, you may forget. That's most likely the possibility. Okay, so to assess, see capillary refill time, blood pressure, pulse, and temperature. Okay, and when we come to see, when we check in the pulse, this is always a good practice that you check the pulses in all the four peripheries. Okay, radial, and dorsal is dorsal is pedis artery on both sides. Okay, by utilizing this practice, you will avoid any acute limb ischemias as well. Okay. So that is a assessment, and in assessment of in addition to doing all those things, so we are going to listen, we are going to perform the inspection, palpation, percussion, auscultation, everything. Look for the ankle edema and those kind of things. Okay, your interventions depend upon again what the underlying problem is or your assessment. Okay, if you think the patient has MI, then you are going to start Mona, morphine, oxygen, nitroglycerine, and aspirin and stuff like that. Okay, if you think that the patient has a heart failure, you are going to start furosemide or the diuretics, prop the patient up, continue oxygen, low dose morphine, like those kind of things. And if you think that the patient is volemic, then you're going to start thinking about giving the fluids, IV fluids or boluses. Okay, always give very clear instructions to the nurse if present, or verbalize if you are alone, as well as you need to show that by your action, by going to the trolley, picking the right material and bringing it to the patient. Okay, so if you simply say that I will give my patient normal saline, maybe 500 mils, it will not be considered done. Okay, so to do that, you need to actually go to the trolley, pick normal saline, bring it to the patient, then only it will be considered done.
Do you need to hang it?
It depends. If there is a stand, IV stand, you can hang it. Otherwise, you can bring it and put by the side of the patient. Okay. In case of hemorrhagic shock, in case where you think that the patient is bleeding and going into the shock because of the bleeding, you will need to give the patient initially IV saline boluses. Then you will need to give patient IV fluid, transfusions. Okay, what happens in your simulation? In most of the time, the guy, your examiner keeps it hidden. Okay, they keep it behind something. Okay, until you mention that I want to give my patient transfusion, you will not be given that. So that is out of the trolley normally. Okay, so in the trolley you will find maybe normal saline, dextrose, ringer lactate, all those things, but the blood will be kept separately. Okay, and blood bag is not visible, and most of the time it is hidden on the side, and they do not want to give you the prompt without you thinking. So it is very important that you keep this in your mind, that you need the patient's transfusion, and verbalize it. Okay, when you verbalize, then only it will be offered to you. There you go, here is your blood, give it. Okay.
If my patient needs urine output in any case like sepsis, should I put urine catheterization in this case?
No.
Just I can work.
That can be done. We are talking about A to E. Okay, that can be done later on. Okay, Mention that in the final plan that because my patient seems to be in a shock, I will I'll continue. I will monitor the input as well as output, and to do that, to facilitate the monitoring, I will catheterize the patient. However, that should be the part of the final plan. Okay. Now, again, going back to assessment of C. Uh, After you've assessed, you check the capillary refill time, you check the temperature, you check the pulse rate, you checked blood pressure. Then you intervene either by giving IV fluids alone, by giving furosemide if the patient has overloaded fluid. Okay, if the patient has heart failure, by giving IV antibiotics, IV fluids. If you think the patient is septic, by giving IV fluids and transfusion if the patient is in hemorrhagic shock. Okay, uh, then you investigate. Mention about the investigations. This is a situation. Similar is a situation where you intervene before you investigate. Okay, you do not wait for the investigation results to come back. Okay, you start the intervention unless you are doing the ECG and the ABG and the VBG, because those are the instant findings and the results where you can intervene very quickly. However, if you're sending the patient for the UNEs to the laboratory, it will take an hour and a half to get the results, so you do not wait. Okay.
What is the fluid challenge? Is it 500 ml?
So minimum should be 250. Okay.
50?
Yeah, a bolus of 250, but you can mention either 250 or 500 mils.
In case of any heart problem, we will not give the fluid.
Yes, of course. No, that can kill the patient. Okay, so you need to be careful. Okay, when you are assessing the patient, I mentioned you checking the pulses. Okay, you can take the opportunity when you are checking the pulses, all the pulses. At the same time, you can also mention that I will check ankle edema as well.
Is there any cases where we give 1 liter bolus? Is there any
I don't.
situation?
I don't know. I think this is more individual performance. Okay, if you are if candidate is lazy, they may need to give it twice. Okay, means if I want to hear you from the from you about the inotropic sport, I may not maintain the patient's blood pressure until you mention that. Okay, so you've given 1 liter of 500 mils, no response. Okay, and again another bolus, no response. Then you mention that I will give my patient I will consider inotropic sport. Then you find the response. In contrary to you, someone else comes and straight away he says that I will give the patient IV fluid. He is given, no response. Then the next thing he mentions, I will give him inotropic sport, and the patient, they found the response. So it depends upon how you act and react. Okay. Now, diagnostic, again we have talked about them. Depending upon what you are thinking, we consider all those investigations. Routine investigations are UNEs, LFT, CRP, full blood count. If you're considering transfusion, or if the patient is coming with the bleeding like the parectal bleeding, PV bleeding, the patient may need the coagulation profile as well as the transfusion group and save of the cross match. Okay, so all those things, depending upon your findings, you do not need to necessarily do the urine culture for the patient where you are not suspecting any infection. Okay, say for example, if the patient is coming with a acute exacerbation of asthma, okay, we are not suspecting any urine problem, so you can do urinalysis. That's always good thing. Okay, there's an instant investigation, but you do not need to consider doing urine culture. Okay, so starting from A to E, now we have gone through A, B, and C. Before we move to D, we are going to reassess the patient from A to C, to look for whether all the intervention that we did are still working, if the patient's airway is still patent. Okay, so that's very important that you consider doing all those things. Okay, now you have reassess a patient, everything seems to be working fine, and now you want to do the D. What is a D in your idea? The D is disability. Disability is not the disability that you get from the injuries and stuff, okay, like the arms and legs disability. It's a disability of the thoughts, it's altered sensorium, disorientation. Okay, so we do not need to worry too much about doing the full-fledged GCS if the patient is talking to you. Okay, so there are two different scales, two different ways of assessing, going through the through D. These are either AVPU scale or GCS. Okay, I normally suggest all the PLAB2 candidates to go through AVPU scale. Okay, AVPU scale is simply you talk to the patient. If the patient is alert, conversant to you, talking normally, the patient is alert, you can mention that the patient is scoring A on AVPU scale. If the patient is not fully actively talking, but he is responding to your voice, okay, where you have to raise the voice slightly more than usual, okay, that is a patient is responding to V on AVPU scale. Then if the patient does not respond to the voice, you give a bit of stimulus, okay, especially in this area, or you can give the trapezius squeeze. Okay, if the patient responds to you in that after that stimulus, you can mention that the patient is scoring P on AVPU scale. Okay, then the next thing that you want to do is check the pupils after assessing the AVPU scale. Okay, always check the pupil. If the patient, look for the pupil's reaction as well as size. Okay, if you find the patient's pupil are pinpoint, okay, go back to monitor, look at what is the oxygen saturation, what is the respiratory rate. Okay, it could be possibly because of opioid overdose. Okay, the patient may be given too much opioid, or the patient may be abusing it. Okay, in most of the situations. Okay, the pupils may be dilated as well. In what situation the pupils can be dilated? Yeah, increased intracranial pressure like hydrocephalus, hemorrhage, subarachnoid hemorrhage, and stuff like that. It can be because of the tumors. It can be because of
Opioid.
not opioid. Opioid cause pinpoint pupil.
Withdrawal.
Huh?
Or withdrawal symptoms.
Okay. Opioid withdrawal. Okay. The patient may have been given some medications like the Midriatic drops. Okay, so depending upon the situation, your action should be followed. Okay, you should intervene accordingly. If you are suspecting that the patient is overdosed with the opioid, what you do is give the naloxone. What is the dose of the naloxone, Selchuk?
I don't know. I can't remember.
So tomorrow is your exam.
Right.
Okay. Mahbuba, what is the dose of? Huh?
400 milligrams.
That's too much. Okay, so if you go back to the notes, important life-saving medications, naloxone, that's 200 to 400 micrograms, okay? It's not the milligram. 200 to 400 micrograms or 0.04 milligram, okay?
2 milligram.
That is maximum dose, okay? And
Do you have the chance to increase the size, doctor? The part of, I mean, thank you.
okay.
Okay.
We were talking about the D. After we have assessed a patient, we need to start the intervention. Intervention is for the drug opioid overdose is 200 microgram to 400 microgram every 3 minutes. Okay, so you can give it. At the same time, keep this in your mind that the patient may start crying of the pain, because once you have given the naloxone, the patient's pain will come back. Okay, so you need to be considering some alternative to the painkillers as well. Okay, then before we move to E, okay, we need to do the glucose as a part of D as well. Okay, in your examination, it will not be considered done, or you will not get the findings until you take the glucometer to the patient. That's very important. Okay, so if you want to check the patient's glucose, do not simply assume that it will be given to you, or by simply asking that may I know my patient's glucose, it will not be given to you. So what they want you to do is that you go and pick the glucometer and bring it to the patient. Then you will get the prompt that the patient's glucose is 1.7, 1.8 or 2.9 or whatever. Okay, and depending upon the findings, you will respond. The response is intervention, essentially. What are the things that you can do in those situations is either you give the patient some sugary drinks if the patient can swallow. If the patient cannot swallow, then you can consider IV, say IV fluids like 10% or 20% of dextrose, depending upon whether or not the patient has the IV line. If there is no IV line, then you need to consider glucagon. So there will be a lot of stuff in your exam you need to look around. Okay, if you simply say it will not be considered done. Okay, you may have already put the cannula. If they want to see your action, they may simply say that and when you mention that I will give my patient 10% of dextrose, 100 mils or 200 mils, okay, they may say the cannula is not working. Okay, which means that they want you to look for the intramuscular stuff. Okay, what we can give them intramuscularly is IM glucagon. What is the dose of IM glucagon? That's very important. So you need to mention that in particular. It's a 1 milligram intramuscular glucagon. Okay, then you need to move forward after the intervention. However, the rule is before we move forward, we need to go back to A, reassess the patient, come back to E now. Okay, reassess from A to D, and then you move forward to E. In E, E is mainly reserved for the patient's assessment, looking for any ulcer, any bed sore, any cellulitis. Okay, it should not be used for looking for the catheter mainly, or the urosepsis for the diagnosis of urosepsis, or for the diagnosis of hemorrhagic shock from the PV bleeding, especially like in PPH. If there is any problem, like in problem in C, so you need to assess a patient thoroughly to find out all the possible reasons. Okay, if you are suspecting the patient has a problem in C because of the postpartum hemorrhage, you do not delay the assessment or uh, inspection of the private area or of the vagina till E. Okay, so quickly do that as a part of C. Okay, if the patient is in shock and there's a postpartum hemorrhage, you're suspecting the patient is in shock because of the postpartum hemorrhage, you simply lift the gown up. Okay, after warning the patient, informing the patient that I want to quickly examine, look for if there's any visible source of bleeding, mention that, cover the patient, then you come to E. E is mainly should be mainly used for assessing and looking for the cellulitis, any bed sores, ulcers, and stuff. Okay, and simply thank the patient, cover the patient, and make sure that we follow all the investigation, we chase them up, and we act accordingly. Make sure that all the help that you figured out throughout your assessment is on their way, or you have some plans from them. Okay,
So, we are checking blood glucose in the E part.
in D,
In the E part.
in D,
Sorry?
in D.
I'm sorry, D part.
Hmm.
But if I suspect my case could be hypoglycemia in the beginning,
Hmm.
am I allowed to
No.
check?
No. Okay, because a patient may have hypoglycemia as well as a few other problems, okay, which can kill the patient before. Okay, say for example the pulmonary embolism or the shock, okay, that can kill the patient before the patient dies from hypoglycemia. Okay, so do not do that. And I recently saw just last week a patient coming with a meningitis, that's 18 years old boy found by mum. He came severely cyanosis, so his glucose was 1.4, I think 1.4 or 5. Okay, and he was all mottled from top to bottom, severely cyanosed, 81% oxygen saturation. So I know that the patient may have the hypoglycemia, but there are many other things that I need to work on before I go to hypoglycemia. Okay, if I'm alone, so my order of assessment intervention would be to start with the airway, then breathing, then circulation, give him IV fluid, IV antibiotics, okay, antipyretics, and then treat the hypoglycemia. Okay, and for the sake of your examination, they do not make it difficult for you. Okay, if the patient has a hypoglycemia, okay, in uroscopy, they make it very easy. They just want to see whether you have the sense of following an order, the guidelines A, B, C, D, E. Okay, as soon as you go inside and you mention that I want to examine the patient from A to E, okay, when you ask the patient, okay, open your mouth, they'll say clear. Okay, which means that you are not wasting a lot of time. When you mention that I want to examine your chest, they say all clear. Okay, I want to examine the patient's circulation by checking the pulse. They'll say everything is normal. Look on the monitor. Okay, so they do help you a lot so that you move to the to D. However, if you simply start by jumping to the D, that will go against you. Okay. Okay, so I suggest you all to download this application. Okay, This is a very good application if you can find on your iResearch. Okay, that's a free mobile application. They gave all the updates. You can find the algorithms and the guidelines. Okay. All right, guys. So now we have completed the discussion about how to approach and how to assess, intervene. These are the major things. We will go to the practice now. Okay, so where we will be practicing on the Simman, and in that part, you will be given the task. Okay, one of you will one of you will read the scenario aloud for everyone. The others will be sitting. They will be looking on how you are performing, and one of you will be performing. I want you to perform it actually as you would do in your exam, so that we can find the mistakes and we can correct them. Okay?
Okay.
Any questions? All right. So it is important. Just a few things that I want to mention, and these are the major mistakes as well that you guys do when you go inside your cubicle. That you simply, first of all, do not look around. So that is a situational awareness. When you go inside, make sure that you look around. What you have, all the facilities and all the help that you can, all the material that you can use. Okay. Secondly, do not simply assume that whatever you ask will be given to you. The third thing is, do not talk to the examiner and do not look on the examiner. Okay, means many of the time the candidate wants to know the temperature and it is not given. They start looking on the examiner. I want to know my patient's temperature. So do not do that. Okay, you can simply mention that ideally I will check the temperature, or I want to know the temperature of my patient. Okay, if you do not get any response, you can again mention that I will make sure that I will check the temperature. Okay, in most of the situation it is given already. Okay, in the cubicle the monitor is your friend. Okay, if you are stuck, always go back to the monitor. Okay, so look on the monitor, and when you are looking on the monitor, it can be very difficult sometimes when you have not done any practice, when you have not seen the monitors loads of time in your life. Okay, it can be difficult what to look for and where to look for, what are the parameters that we can see. The main parameters are that you can see on the monitor. There are many others. The main parameters that you can see on the monitor are related to breathing and circulation. Okay, and when you are looking at the monitor, always look in that order. Okay, look for the breathing, respiratory rate and oxygen saturation. Never look them in isolation. So when I say in isolation, it means that when you are looking at the respiratory rate, always look at the oxygen saturation at the same time. Okay, in combination. And when you are looking on the patient's blood pressure, always look for the pulse as well. Okay, so the first parameter that you need to look for on the monitor are related to the respiratory rate. Okay, then you look for the parameters which are related to the circulation. Okay, and talk to the patient. Do not give running commentary. Okay, that is very, very important that you talk to the patient. Mention that, show sympathy, empathy, everything. Okay, and whatever you want to do with the patient, mention that to the patient. Okay, do not simply say I would like to give. This is the commonest thing and the commonest sentence that comes out of most of the candidates. They say I would like to do, I would like to do. No, that is wrong approach. Simply do that. I will give you IV fluids. Okay, if you want to give the patient IV fluids, simply mention to them that I will give you IV fluids, I will give you IV antibiotics. Okay, I think that you have the temperature. Okay, and or I see that you have the temperature, I'm going to give you some paracetamol. I suspect that you might have allergic reaction, I'm going to give you some medication that's adrenaline into your thigh muscle. Okay, so like those kind of things. So talk to the patient, do not simply give us the running commentary. Okay, you guys should be doing everything when you are working with us today. Okay, so our Simman has all the features, a respiratory rate, and respiratory sounds, cardiac sounds. They change according to the situation, so you need to focus. They have the pulse as well. It can be absent, present, regular, irregular. So you need to uh, actually respond according to the situation that you will see during the practice. Okay. So we have done all the discussion, no more discussion. We will go for the practice now to the cement room.